Hi, everyone. Welcome to our presentation. Today, we are going to be sharing some thoughts on a few projects where we did some COVID-19 preparedness for healthcare institutions, sharing some of our stories and lessons learned, as well as long-term impacts for those projects. We'll give you a brief overview, and then you'll hear from each of our panelists on their case study. And we're going to reserve some time at the end to answer any questions you might have. So please feel free to add those into the chat window, and we'll address them when we get to the end. I'd like to take a minute to introduce our team. I'm Sarah Kuchera. I am with WSP, and I am in our San Francisco office. I am head of our buildings group for California. April, would you like to go next?
Yes, I'm April Woods. I'm in our Florida buildings practice, and I am the department head of our mechanical engineering department down here.
Great. Todd?
I'm Todd C. I'm also in the WSP San Francisco office, Senior Vice President, Mechanical Engineer. I've been with the firm about 30 years. And Derek?
Kevin, you're up next.
Kevin?
Hi, I'm Kevin Chow. I'm in the Dallas office for WSP. I'm a Senior Associate Mechanical Engineer.
Great. Well, we know a lot's been going on over the last year with the COVID-19 pandemic. Some of the numbers are staggering when you start to think about where we're at in terms of overall case count. The loss of revenue is over $300 billion for our health systems for, deferred procedures and those types of things. We're also starting to see a shift in how care is delivered. In April last year, they saw a 69% increase in the volume of telehealth visits. And we're finding that today, the vaccine is rolling out with over 60 million vaccines distributed at this point. So what we'd like to do is we'd like to go back in time to spring of last year when the pandemic started. We have 3 case studies to share with you the work that occurred at some institutions across the United States. And I'm going to start off by handing it off to April, who's going to share her case study first. April?
Great. Thank you so much. So this is Parkview Regional Medical Center in Fort Wayne, Indiana, and it's a campus that is really near and dear to my heart. I have been doing the work there on behalf of WSP since 2007 and have been able to help design and construct over 1.5 million square feet on the campus. This project included a 165,000 square foot bed tower expansion. That was an expansion to their existing tower. It includes 7 floors, the top floor being a penthouse that houses the air handling unit systems, as well as electrical systems and medical gas systems. And then it is a full patient towers levels 1 through 6. With 4 through 6 being built out day 1 as medical surge rooms, and then the lower floors were mostly shell with provisions for future med surge. Also included was a central plant expansion to help with the infrastructure of the systems. So next slide. So we started the design out back in 2018, and the topping out for the tower was in March of 2019. In March of 2020 was the start of level 6 work. And so how we had done the construction schedule was as a phased opening starting on level 6 and with then the continuation of level 5 and 4 and then the shell floors. And this was really just to allow for the medical system to have early patient beds. So level 6 started, we had drywall in, we had overhead and in-wall started. And as we all know, mid-March, the COVID-19 pandemic hit. And really the design and construction team was tasked with how do we take this existing floor and potentially convert it into kind of a permanent COVID floor. Obviously already undergoing in operations was Parkview looking at some temporary provisions throughout their campuses of areas that they could easily convert for temporary measures, but they were really interested in what could be happening in this tower for kind of a future pandemic, and also to help with the current COVID case. So we're tasked with not only meeting the September 2020 opening date of this floor, but also potentially pulling it up by a whole month. So not only changing out some of the infrastructure overhead, but also aggressively working through the construction schedule, which we were able to successfully do. In October 2020, the tower was substantially complete, and then almost immediately we started planning for the level 3 build out, which would also include pandemic provisions. And so part of that was really reviewing first with the Indiana Department of Health. So the first thing we looked at was the waiver that they had issued for the temporary COVID measures, which really included negatively pressurized rooms that were fully exhausted. And we were really able to utilize this waiver for our permanent strategy. So right away, we met with the Department of Health, kind of talked through what we were thinking. We also used guidance from ASHRAE 170 and the Epidemic Task Committee that had been putting together the temporary provisions, and also some permanent thoughts of how they would eventually adopt the codes, and really use that as kind of our baseline of how we were going to design the systems. One thing that really worked in our advantage is that the Department of Health was not requiring us to increase the air change rate to airborne isolation rooms, which would have been pretty dramatic. We would have been going from 4 air changes to 12 air changes of exhaust. And so with that, we were able to keep the patient room supply airflow at just above the 4 air changes. We had it designed at about 5, and then we were able to increase the return, which then became our exhaust path. So on the next slide, it kind of shows you a little bit about how the strategy works here. So rather than returning the air back to the air handling unit, we were able to segregate the airstream into a pandemic exhaust system. This was really strategic, just based off of how flexible we had designed the air systems, with 2 air handling units in the penthouse that distributed all the way down the tower, separated by the smoke compartments. It allowed for each individual smoke compartment to be operated individually, but it allowed for all of that air, rather than returning back to the air unit, to be fully exhausted. However, we were still able to keep the rooms that had special pressure relationships, like a clean supply room, to still maintain positive pressurizations. So with this strategic motorized damper operation, rather than returning the air back to the unit, we were able to close that damper and open the damper that would then go to the exhaust fan. Something that is important to note is that it does require a manual pre and post test and balance every time they want to switch the modes, which hopefully is not often. After we get out of this COVID circumstance, they will be switching this back over to a med-surg operation, but it will require a little bit of downtime to get all of the rooms back to the pressure relationship, and also back to the air change rates that they need to be. As shown on the next slide, we have kind of just a diagram of how the air distribution works. So I mentioned that, the air handling units do reside in the penthouse. They distribute down throughout the floors. We went ahead and provided new utility vent set fans with bag in, bag out filters, HEPA filters, located on the penthouse roof. Those were specific to support the 6th floor. And then we already had decided as a team and gotten direction from Parkview to design provisions for the 3rd floor to be full pandemic operation, which included putting in 3 additional exhaust fans to serve that floor, in addition to all of the shafts, which also was a pretty big change to the floor plans. With that as well, we had pressure monitors provided in all 6 of the patient rooms, so there could be verification that we were meeting negative pressure prior to anybody entering those spaces. And of course, as we increased the exhaust quantity by quite a bit on these floors, we also verified that the coil and humidifier was sized adequately, both for cooling and heating system. And of course, there were some modifications made to the control sequences for the automatic control of those motorized dampers, and also allows them to do some fan testing sequences when they're not in pandemic operation. So with that, we were able to use that design for the 6th floor and move into the 3rd floor. So essentially the tower was substantially complete late last year in October, and just almost immediately after, we were already starting to prepare how we were going to design the 3rd floor. Unfortunately, still with their COVID census being what it was over the winter months, they were concerned about what it would still look like come this spring and summer. And so we are prepared for this 3rd floor build out, which is planned to be completed in August to have has pandemic operation, which they can decide at that time if they would like to have it as a progressive unit or in full pandemic operation. One thing we did improve upon from the 6th floor that we decided to do differently on the 3rd floor is we are giving them 6 rooms that have automatic operation with the utilization of air valves to change that pressurization. And that is something we also had discussed with the Department of Health, something that they will allow them to have these rooms to be somewhat switchable between the positive pressure and negative pressure relationship. And this can be great for other reasons outside of a pandemic, potentially just during a seasonal flu, if they have a need for some just kind of isolated patients that maybe don't need the airborne isolation room, they can use those 6 rooms. On this floor plan, I have also 4 red dots. Those are what the permanent airborne isolation rooms are. So of course they do still have those on the floor. And then we did design this floor to be flexible so that it can be fully exhausted as well through the different sequence of operation. So I think overall, this approach has really helped Parkview not only during this pandemic, but also any sort of future pandemics that they have, but also just giving them the flexibility and the infrastructure to run these floors as normal med-surg or progressive units. So with that, I'm going to turn it over to Todd, and he's going to talk a little bit about his project over at North Bay.
Thanks, April. Our story starts March 16th of last year. We were invited on campus to take a look at a new project with the North Bay Regional Health. And with the real significance to that date is as we wrapped up our meeting, I got in the car and heard on the radio that the 7 Bay Area counties around San Francisco had all instituted a shelter-in-place requirement, and that really sort of set forth where we wound up going forward. So North Bay had identified the possibility of the pandemic, and to get out ahead of it, had started looking at their facilities. And one of the things that they wanted to look at was taking a CVOR that they had recently remodeled and was about to come online, and they wanted to utilize that as a treatment room for COVID response. So when we look at this diagram, the existing facility, the red area is the existing CVOR that had recently been remodeled. The sterile core had been taken offline as part of the remodel, and the adjacent OR4 in blue was planned to be remodeled after the CVOR was completed. The hospital had the idea of taking the CVOR and converting it to a negative pressure OR to prevent the transmission of the virus out from the OR. The OR was planned to be used specifically for intubation, and knowing that is one of the highest incidences of transmission, they really wanted to have the negative pressure OR. North Bay had gotten out ahead of this process by talking to the California OSHPD. The OSHPD process typically takes about 80 days for their initial review. They allow 90 days for design team response and 40 days for their back check. And then that becomes an iterative process. So with the time that those reviews typically take, North Bay had reached out to OSHPD and said, how can we work together? And OSHPD had agreed that temporary measures could be put in place as long as everything met code. They weren't going to go through the formal OSHPD review process. And so what we did was, working with the hospital, the existing facilities, we were able to reconfigure an air handling unit that serves this area specifically by closing off the return air damper, using that fan, putting it into exhaust mode. We added Hepa filtration on that exhaust and a stack to take the exhaust up and away. We converted this into a 100% exhaust system without any return air. When we presented that to OSHPD, their only comment was code will require for the OR to be positive with respect to the adjacent spaces. So what we did was create negative spaces around the OR and balance the OR so that it is positive with respect to the adjacent sterile core. We created an anteroom by adding 2 sets of doors and turning what was a corridor into an anteroom, exhausted the anteroom so that it's negative with respect to all the adjacent spaces, and maintaining all the air change requirements. So by good luck, the existing OR4 was offline. We were able to rebalance the system and reconfigure to create this temporary arrangement so that they had a procedure room for intubation of COVID patients. And then all the equipment can be reconfigured at the end, or submitted through OSHPD for permanent installation. Kevin?
Thanks, Todd. So I'm going to talk about the OU Medical Center adult patient tower expansion that we had in Oklahoma City. And this project was a little over a 400,000 square foot tower expansion to their existing facility. It included 36 ORs, 4 patient floors with approximately 36 patient rooms on each floor, and one of those patient floors was actually going to be shell. So as the pandemic actually hit, we did start looking at different options, just like April and Todd had told you before. And as we were going through, we were trying to figure out how we could design the project such that when they opened, it would be able to accommodate some of these COVID patients. That happened in March, and during the summer, the state health actually came to OU's administration and asked them to start looking at ways to accelerate the project. So we were about 85% of the way through construction at that point. And Sarah, next slide. So at that time, the state actually came to OU to see if we could accelerate the project, or at least for some of the patient floors, because the projected pandemic surge for the summer or the fall and the winter was showing that they were going to need more beds. So since OU was actually the largest hospital expansion in the state at the time, they were trying to find ways to open up more hospital beds. So that way they didn't have to go through and look at converting hotels and other public spaces as other states had been doing. So trying to get out ahead, and as a state, they were trying to get OU or approach OU to accelerate the program. So with that being said, we started looking at different ways of going about that, and some of the different roadblocks that we had to get that done. So for us, the lower floors of the patient tower were the ones that were furthest along, so they made the most sense in order to accelerate. So with that, we also had construction ductwork and piping risers complete, and all of our major equipment was already installed. Another big thing that we had to take into consideration was the fact that while we were opening up these first 2 floors, we also had to keep in mind that construction workers were going to be working in the facility once we opened up those floors, and how could we make sure that they remained safe as well. Next slide. So with that, we looked at a few different options. On the screen, you can see a one-line diagram of how the building was set up mechanically. We had one floor in the middle, the 4th floor for this project, that was a mechanical floor. It housed most of our air handling units that served the new tower. We had, just like April's project, had 2 different air handling units that served those patient towers. The reason why we went with that 4th floor mechanical floor is this project is slated to have 4 additional floors. So we wanted to make sure to minimize the roof mounted equipment. So with that, having the floors that we were going to turn over be close to the mechanical floor made some of the different options that we looked at a little bit tougher to do. We did look at separation of airstreams, just like April's project, with the fact that we were using a mechanical room as our relief plenum as well. It made it tough to make sure that the construction workers were safe, and then also getting the air flow out of the building. We also looked at putting in UVC inside the airstreams. UV lights were scarce to find at the time. It was also still not 100% proven for COVID-19, so it was something that we had to make some quick decisions. We already had UV lights in there for coil cleaning, but whether or not we were going to step up the UV intensity in order to get a little bit more airstream disinfection. We also looked at HEPA filters in the supply airstream. Knowing that the air handling units were already online and in place, we did not have a means to add an additional final filter section. So we were going to have to retrofit the existing air handling units. It posed some problems as well because a lot of other facilities were looking at it and trying to find HEPA filter racks and HEPA filters was starting to become a little bit of a challenge. So another option that we looked at was HEPA filtered negative air machines. So due to the speed of the project and some of the decisions having to be made quickly, this ended up being the decision going forward. It was something more temporary. It wasn't a permanent solution. So what we did in our case was we reduced the supply air inside of each one of the patient restrooms. We also reduced the return air inside of the patient rooms to help make that negative pressure room. We then installed a negative pressure air machine that was HEPA filtered and then connected it into the return system such that all the air coming out of a patient room was being HEPA filtered before it went back to the main system. So, in fact, what happened was we did not end up having a permanent solution, but what they do have is something that is scalable. It was something that if they needed to move into other parts of the facility, which they ended up needing to do, they had a way and a process in which to do that in the rest of their facilities.
All right. Thank you to all of our presenters. If you have any questions and would like to add them into the chat, we'd be happy to field any of your questions at this point. One of the things that, as an organization, we found kind of interesting and challenging is as this pandemic kind of hit us in the spring, we did a lot of collaboration across the United States, but also more importantly, across the globe. And we found that some of our team members in Asia offered us a lot of good advice. They've been designing for pandemic wards or pandemic floors for quite some time. and operate those seasonally. And so a lot of the design principles that we deployed on our projects were things that we had deployed with them in their projects there. We've also seen with our work with pediatric facilities that seasonal flu is something that they have to work around, and so we'll see, as we move forward, how that impacts their design decisions as they take on new projects for that as well.
Yeah, and one other thing that I would say as well to kind of echo what Sarah was saying is, we used some expertise that we had around the world to figure out how to design these floors. But also we do have several of our experts that sit on some of the ASHRAE 170 committees and some other committees that were kind of part of the forefront of the pandemic to figure out these solutions of how we could implement these both from a temporary standpoint and also for permanent pandemic strategies. And they're actively part of committees and task force that are moving forward with code implementation. I think that's something that you might see that's a little different from all three of our stories is we were all within different jurisdictions that were either requesting or requiring different strategies. And I think as we move in kind of to this post-COVID world, we'll be able to see how a lot of that language and that implementation will be moving forward within the code, which will definitely change how we potentially do design in the future, and even more importantly, how facilities will operate these during these times in the future. So I think we've all learned a lot from it, and we're all working towards, just like everybody in the design community, of how to make our designs very sustainable for the future.
Thanks, April. Does not look like we have any questions here. Give one more moment. If you do think of other things and would like to follow up with us, we've included our contact information. If you'd like to reach out and follow up with thoughts or questions, we'd welcome your input. All right. If we have no other questions or comments, I think that's it. Thanks for your time today, and we appreciated sharing our stories.